rounds. We have a very special grand rounds today with several speakers, courtesy of the Division of Radiation Oncology. Just before we get started, just a reminder that we ask you to please leave your questions till the end and enter your questions in the chat. And at the end of the presentation, please answer a very brief survey. This will also let us know that you were present today. So we have several speakers today, as I mentioned, courtesy of the Division of Radiation Oncology. And I would ask our Chief of Radiation Oncology, Dr. Tariq Hijal, to please present the topic and present the speakers. And Dr. Hijal will also moderate the questions at the end of the presentation. So Tariq, thank you so much for being here today and bringing your team. And the floor is yours.
Thank you very much, Nadia. It's a pleasure to have today a team composed of radiation oncologists and cardiologists that is going to talk about stereotactic cardiac radioablation for arrhythmias. So the first speaker will be Dr. Joanna Alfieri, radiation oncologist and program director in radiation oncology. And throughout her talk, after the objectives, she will actually present the rest of the speakers who are also the team members on this project.
Thanks. So I'm going to share the screen now. Thank you, Dr. Hijal. As Dr. Hijal said, we're talking about stereotactic arrhythmia radioablation for ventricular tachycardia, which we'll be referring to as VT. And I thought I would go over the objectives before introducing the team. So the objectives for this session is to explain invasive and non-invasive ways to map ventricular tachycardia, review the data as the rationale for radioablation of VT, evaluate a plan for this type of treatment, describe the basic radiation physics relevant to ablative radiotherapy to the heart, and then discuss an MUHC trial for such patients. So this is a list of our team. It's a large team and an unusual union of specialties. Dr. Martin Bernier is a cardiac electrophysiologist here at the MUHC. He trained in cardiac electrophysiology at Harvard, and Dr. Valeria Anglesio is a fellow here in their division. Part of our team are medical physicists, Dr. Piotr Pater and Dr. Gabriela Stroyan. They have obtained their PhD in physics and work in the medical physics unit at McGill University and are assistant professors in the Department of Oncology. And the radiation oncology team includes Dr. Ian Gerard, who's a resident in radiation oncology with a master's in medical physics and a PhD in biomedical engineering, and Dr. Neil Kopek, who is a radiation oncologist at the MUHC as well, and who specialized in stereotactic body radiotherapy. So we'll go ahead and present a clinical case now.
Thank you, Joanne, for the introduction to the team. So I'm Martin Bernier. I'm one of the cardiologists, electrophysiologists here at the MUHC. And I will talk a little bit just to anchor the talk around a case to illustrate the clinical need for what we did and for this program that was started. And again, highlight the very unusual and spectacular collaboration between specialties to make this happen. So if we go on next slide, it's a 65-year-old gentleman at the time who has the common comorbidities of coronary artery disease, including diabetes, hypertension, prior bypass surgery in 2014, had an ICD implanted in 2013 for primary prevention, given a decreased ejection fraction in the range of 30%. With some mild CHF symptoms that were fairly compensated. and who, interestingly, there's also a family history. Is the patient's father was one of the early receiver of a heart transplant in the past. We don't have much detail about that, but certainly was a question of whether there was something familial in the form of coronary disease or predisposition for coronary disease, or other genetic or mixed type of cardiomyopathy. In any event, this patient went on to develop events, VT events requiring shock, and then an ablation was performed after escalation of antiarrhythmic therapies failed, and that was back in 2017. Next slide. At that time, I mean, the usual course and sort of tools we have in the arsenal to control arrhythmias in patients that have scar and scar-mediated VTs were sort of being used, and that both include antiarrhythmics in the form of amiodarone with reboluses, mixilitine, the highest tolerated dose, and good aggressive control of heart failure, as it is a known precipitant for VT events. Next slide. And then in spite of that, I mean, I can say that during the first VT, there was a fairly extensive modification, what we call substrate modification. And Dr. Anglesio, our fellow, will go a little bit into mapping and how we go about these things. But let it be, let's just say for now that we did ablation to the extent that we could. And in spite of all that, a year and a half later, we presented with syncope. And this is on the right side, taken from the interrogation of the device. And we can sort of see the little squares that sort of accelerate and then go into what we call the VT zone, and then that were treated with the little rows of dots at the bottom, which are therapies. So it's actually the dark dots accelerate faster, so the ventricle starts going faster than the atrium. This is what the dot plot tells us, and it's really classic for a VT event. And then you see that there's a burst that's delivered that's even faster. So that's the device sort of pacing into it faster than the VT to try to break it. And then it slows it down, but not quite terminates. And the patient goes on to have eventually more therapies and eventually a shock. Next slide. At that time, the patient was essentially had not evolved much from the ejection fraction point of view, with the dilated LV and the basal and inferolateral akinetic regions predominantly. No major valvular disease. Next slide. Extensive coronary disease with native vessels that were, for the most part, occluded, and patent vein grafts with no obvious culprits. I mean, this is a whole other discussion, whether ischemia and the role of ischemia in patients with monomorphic VT. We know that it's probably not that prominent. It tends to be part of the workup in general, but these are really scar-based and scar-dependent arrhythmias more than ischemia-driven. Next slide. And so the maybe at the time showed a massive perfusion defect at sort of inferior and inferior lateral portion, part of the left ventricle. So what you see here, and these are sort of different angles, the donut view, which are in the sort of center. So you imagine the heart cutting in a short axis from the base towards the apex, and you see the areas that don't light up at all as areas that are not perfused and not essentially viable. Next slide. So the patient was taken to the lab again to see if there was anything further we could do. And without going into too much detail, because again, Dr. Anglesio will do it in a second, we did what we call a voltage map, which is essentially you measure voltages at the tip of a catheter placed inside the heart. And the local voltage gives you an idea of the health of the tissue that's right adjacent to it. And when it's red, it means it's below a cutoff. It's a very low voltage, and red essentially means scar. So you can sort of see quickly here in this shell that's reconstructed that there's extensive scar And we sort of, the view on the left is sort of posterior view, sort of a PA view of the heart, which shows a very dense scar on the inferior portion, extending a little bit laterally, which correlates with what we had seen on the echo. Next slide. And then without showing you all the ECGs, the patient developed multiple recurrent VTs that were easily inducible, that shared, for the most part, an ECG signature that was suggestive of an LV lateral origin. And if you look, I mean, you see the ECG on the left side, they all share, well, the top one is very negative in lead 1. It's positive in V1, which suggests it's coming from the left ventricle. And the ECG at the bottom right is also slightly different, but positive in V1 and negative in lead 1, also suggesting of a lateral focus. The bottom left is positive and there's a superior axis, perhaps more inferior. So a lot of activities that originated from the area of the scar. And some of those ECGs had signatures suggestive of a deep focus or perhaps even an epicardial circuit. And for that reason, one part of it was that they were extremely hard to, they were not tolerated hemodynamically, which made ablation during tachycardia not possible. And targeting those circuits to destroy them, which is what we do in ablation, was very difficult because we had clues that some of those circuits were intra or deep myocardium or even epicardial. Next slide. So that's the introduction to the case, and just to illustrate how you sort of eventually run down the course of options that we have, and then how we end up needing something new. And so we're stuck in a situation here where we have someone who's a very predominantly an electrical disease, where he's not in much heart failure. If he's not having VT, he's doing okay. So it's I'll leave it to Dr. Anglesio now to tell you a little bit more about the mapping that I just talked about.
Okay, thank you. So I will talk about how do we map ventricular tachycardia. Next slide. So monomorphic ventricular tachycardia is most frequently observed in patients with structural cardiomyopathy. The mechanism involved is the re-entrance through a scar. The slow conduction in the scar region is the reason why the arrhythmia perpetuates, and these are the areas we need to treat to avoid further arrhythmia events. Next slide. The first approach of VT management is arrhythmogenic drug therapy, for example, sotalol or amiodarone. On the other hand, we have the implant of a cardiac defibrillator, which is indicated in patients that had already had an episode of VT and no reversible cause to prevent further sudden death episodes. And finally, for the patients that are refractory to the medical treatment, catheter ablation is the gold standard treatment nowadays. Next slide. The problem is that a significant number of patients have recurrent VT episodes despite all these treatments. Certain patients are too sick to undergo several invasive treatments. And as we all know, recurrent episodes of VT carry high morbidity and mortality rates. That's why we need to find alternatives to treat this type of arrhythmia, and that's where stereotactic ablation, it's a recent approach that aims to find a solution to this problem. Next slide. As we discussed before, the scar is the critical area that allows the arrhythmia to perpetuate. To identify this region, we use functional information that makes reference to electrical information, such as ECG, invasive mapping, and non-invasive mapping, and structural information that includes different types of cardiac images to localize the scar. Next slide. The EKG is a really important tool to assess VT because it's fast, cheap, and no invasive study. The baseline ECG will give us an arrhythmia whether the patient have a scar and its location, if we find, for example, a Q wave in the ECG. If we have an ECG during the tachycardia, it can be analyzed, and the morphology and the axis can help us determine the origin site of the arrhythmia. That's why we encourage everyone to try to get a 12-lead ECG if possible during ventricular tachycardia episodes. Invasive catheter mapping, next slide. Invasive catheter mapping is a procedure that enables to create a 3D electrical map and an anatomical image from the heart. It's the gold standard for VT circuit visualization, and the main objective is to induce clinical VT and identify the electrical circuit. That's what Dr. Bernier was trying to explain. We use catheters to see inside of the heart, to see the electricity inside of the heart. The idea is to induce the clinical ventricular tachycardia and to map the circuit. If it's possible, sometimes we cannot induce the tachycardia, and sometimes the patient does not tolerate the tachycardia, so this is not an alternative. In that case, this invasive mapping can also help us determine areas that have slow conduction, and that slow conduction is also suggestive of abnormal tissue. Next slide. So this is an example of another map we can do during invasive mapping. This is a voltage map where we settle some ranges, color ranges, and that helps us build the information of the muscle, the scar tissue in the muscle. So here in red, we can see the low voltage areas, and that low voltage areas represent the scar tissue. Next slide. Electrocardiographic imaging is another technique that is used now to map. It's really new, and like everything that's new, it's expensive and not available anywhere. And it also has an important thing, that its reliability and reproducibility is not well established at the point. But what it does is that merges the information in the ECG and anatomical information in a CT. But as I said, it's real expensive, and we don't have it here at this point. Next slide. MRI is the best way to have a no invasive imaging of the scar and the architecture of the heart. It also gives us information about the motion of the heart. An important thing about this is that patients that have an ICD, sometimes it's not compatible for MRI, and also some other patients have abandoned leads, and this can make it difficult to do an MRI on them. That can make it risky. We don't have to forget that this study is better if we use contrast, like better quality study. So the renal function can be also a limitation to do this study. Next slide. PET-CT is another possibility. Since the images are actual, it's easier to import them to the treatment planning software. But on the other hand, the subjective windowing and the different interpretations are possible. Also, the renal function might be an issue in this kind of imaging. Next slide. Regarding SPECT, it's much more widely available than PET. Nevertheless, it does not provide anatomic imaging, so it's important, not provide anatomic imaging that it can be imported to the software planning, so that makes it harder. And it's a study that's not that sensitive, and it is useful for regions that are very diseased. It helps us visualize very diseased regions. Next slide. To finalize, the echocardiogram is widely available. It's not expensive, but it is operator detective, but it's also an alternative to visualize the scar in this type of patients. Next slide. Okay, to sum up all this information, we have the functional information that can confirm the clinical VT generators and that suggest anatomic substrate. But it's also, but really only demonstrates the electrophysiological behavior if we have this information during BT. And the patients we cannot get the BT via simulating or that don't tolerate BT, it will be harder to get this information. It's not useful. And for structural information, we have to take into account that not all scars are arrhythmogenic. There are some scars that are really dense, and electrical conduction, well, then that not allowed electrical conduction to go through them. So maybe these scars are not involved in the VT circuit. We have to take that into account as well. Next slide. So our purpose as electrophysiologists to help in this part of the study is to identify and evaluate the persist target, like to get to combine all these tools we have to give the information of what's the most accurate and precise target spot to do the ablation. Thank you.
Thank you, Dr. Anglesio. So now I'm going to take a few minutes to go over kind of some of the early studies, both preclinical and clinical, that gave us this kind of wild idea of incorporating radiation therapy for these patients. Next slide. So we're take a few seconds to talk about radiation biology and then go over an important preclinical study and the landmark investigations that were done clinically to kind of motivate us and spark excitement for this type of treatment. Next slide, please. When it comes to the radiobiology of cardiac tissue, there's kind of 3 cell lines that we're most interested in. Initially, the myocytes, which are post-mitotic cells, are very resistant to radiation. They're not dividing very often, so we're not super worried about them when it comes to the actual treatment of the radiation therapy. However, the endothelial cells are very radiosensitive. We know that after receiving some radiation, they promote inflammatory response. Harness in different areas of the body when we target them for treatments. However, in this type of treatment, the type of cells we're interested in is called the fibroblasts. And the fibroblasts are relatively resistant cells, and we know we can differentiate them into myofibroblasts, something that you may have encountered as radiation-induced fibrosis, but that takes somewhere around 3 to 6 weeks, usually at least 4. Next slide, please. And based on this, some early preclinical data and a study was done using mini pigs. And what they did, this group took 9 mini pigs and decided to give between 17.5 and 35 gray in a single fraction of radiation therapy to measure how much dose it would take to create a mild to moderate amount of fibrosis. So after these pigs were irradiated, 6 months later, they had a repeat electrophysiology and MRI scan, and then they were evaluated to look for the fibrosis. And as you can see on this sigmoidal curve, which we call radiation dose response curve, right around 25 gray is where we had this mild to moderate level of fibrosis, and what's going to motivate what I talk about in the next slide. Next slide, please. So in 2017, there was this first kind of initial organized landmark investigation for this clinical cardiac SBRT. So similar to what Dr. Anglesio described, these patients were imaged and mapped from an imaging and electrophysiology point of view. There were 5 patients with severely refractory ventricular tachycardia. After their mapping was done, they had a CT simulation to plan their radiation therapy based on all this previous imaging. They were given 25 gray in one shot based on that other study that I described before. Next slide, please. And the results were quite impressive. What we saw is, you can see these curves here. On the x-axis is the time since treatment, and the y-axis is the amount of VT burden they're having. Since their treatment, essentially all of them progressed towards cure from their ventricular tachycardia. The curve in orange, the patient passed away from a stroke. It's unclear if it was treatment related or not due to the highly comorbid nature of these patients, but it was reported as a significant adverse event. And within 6 weeks, most of these patients were off most of their antiarrhythmic medication. The most curious part, though, was the response to this treatment was happening within the first couple weeks of the treatment, and not in that 3 to 6 week time frame that we would have expected. Next slide, please. So the same group organized another trial called the phase 1, phase 2 trial called the Encore VT trial. So similar structure, except this time they had 19 patients, again with a very high burden of VT and very resistant to all their previous treatments. One of the patients passed away before treatment due to unrelated cause of neurosepsis, so they only had 18 patients, and their primary endpoint was any reduction in ventricular tachycardia. And 17 of 18 patients met this treatment after the single dose of 25 gray and 1 fraction. And on the chart on the right here, you can see the blue bars represent the cumulative amount of VT burden for the 6 months before treatment, and the red bars showing the cumulative amount of burden for 6 months following treatment. And we see a pretty impressive reduction. Next slide, please. As I was alluding to before, again, this treatment effect happened earlier than that 6 weeks that we would expect to have this fibrosis set in and cause the effect. So while our early preclinical data suggested 25 gray to create this fibrosis, our early clinical data suggests that fibrosis may not be the endpoint correlating with treatment success. So it's something that's still unclear at the moment. And it's important to note with this 25 gray, there were some major toxicities reported related to esophageal bleed, a gastropericardial fistula, a fatal stroke that I mentioned, and some worsening pericarditis and CHF. Next slide, please.
So I'll be talking about the current clinical landscape and trials that are out there right now. There's really not much. There's numerous case reports and case series, initial experiences, but pretty much that sums it up. So for example, this is one report focusing on magnetic resonance imaging radioablation of a single patient who received 25 gray and had sustained control at a 3-month follow-up. The following, this paper was actually the first published paper of negative results. It was a 2-center study with 5 patients who actually did not have any effect on their arrhythmia, but luckily at a 12-month follow-up point, there were no treatment-related toxicities from the radiotherapy either. This is another published report of a single patient, first experience in Germany, who had the same dose to the substrate and subsequently had a significant reduction in monomorphic VT and ICD shocks. And finally, we added our experience to the literature of our first 2 patients, one who was you learned about earlier on in the presentation, and another one who has VT episodes have completely resolved and is being weaned off antiarrhythmic medications. Current clinical trials for cardiac SBRT are not many. There's this trial being run in Germany. The Reventa trial opened in November 2019. Its goal is to be multi-center in Germany, recruiting 20 patients with a planned interim analysis after 5 patients. That's because their primary endpoint is safety. So they're looking at treatment-related side effects within the first 30 days after radiosurgery. Their secondary endpoints are VT burden, reduced ICD shocks, and quality of life in the first year following radiotherapy. We also have a trial here at the MUHC, which you'll hear about a little later in the presentation.
Okay, so to come back to the clinical case, I'd like to walk you through a little bit more concretely how we proceed in developing a stereotactic ablative VT ablation plan for these patients. Next slide. The first step, just a couple of words on what radiotherapy is without digressing too much. The point of this slide here is to show you the different technological platforms that exist to give what's essentially all the same thing, basically external beam radiotherapy. And what is that? More specifically, we're talking about the use of X-rays. High energy X-rays that are emitted from the head of the machine. The patient is lying on a table and the head of the accelerator rotates around the body of the patient with the X-rays being emitted from the head directed towards the target, with the tumor generally within the patient. But in this context, we're talking about a non-cancerous target, a lesion, a scar, a substrate within the scar of the heart. Some of these names might mean something to you, Cyberknife, tomotherapy, but what I wanted to convey to the audience is that if we talk about Cyberknife, we're just talking about a particular platform for delivering high-dose, high-precision radiotherapy, i.e. stereotactic body radiotherapy. It's a brand name, if you will, okay? Yeah, so we don't refer patients for Cyberknife therapy, we refer them for radiosurgery, SBRT, the principle of radiotherapy, which can be delivered on different platforms. We do have Cyberknife at the MUHC. We used to have a tomotherapy unit when we were still at the MGH, but now all of our radiosurgeries are done either on the Cyberknife unit or the TrueBeam linear accelerator. Next slide, please. I don't want to reiterate, but the name of the game is to contour out, identify the target within the heart. That's been done before the patients come to the Department of Radiotherapy via the various means, functional and structural imaging approaches to identify the substrate within the heart. And our job now is to translate that information concretely. We need to draw out our target for radiotherapy within the heart. So we're going to take this information, in this case for this patient, the voltage mapping, identifying the inferior and lateral wall of the ventricle. We can move to the next slide, Joanne. As well as the myocardial perfusion scan that we had in this case, which was once again pointing the finger to the inferior wall from the apex to the base of the heart, as well as the distal aspect of the anterolateral wall. In this particular case, frustrating for a radiation oncologist, I like to work with the structural imaging because it's more concrete. We can fuse that imaging to our simulation scan and have a more direct visual of the area that we want to draw out basically on our simulation scan. In this case, when we're looking at non-anatomical imaging, then there's a bit more guesswork. Next slide, please. And that's when I really need to rely upon our cardiology colleagues to be sure that I'm drawing things out correctly. First appointment in the Department of Radiotherapy, the patient is invited to come to our department, DS1. No treatment that day. What is the first step? They need to undergo what we call a planning simulation scan. And specifically, it's a 4D CT scan. 4D, fourth dimension being time. What is the idea there? The heart, of course, is not a rock sitting like a lump in the chest. It's a muscle, it's beating, it's moving, as are the lungs. And we need to take that movement into account because we don't want to miss our mark. While that heart is beating, while we're taking in air, our target that we've nicely delineated in yellow there within the inferolateral wall of the heart, that's going to move. And when we do our four-dimensional CT scan, essentially what we're doing is we're monitoring, tracking that movement. So the images that are acquired in the different phases of respiration are then collated. And what we've got is a series of studies that allow us to, I wasn't able to incorporate it into this presentation, but created a little movie, a cine, where we can see that the movement of our target and adjust our treatment volume as a function of the movement. So as much as possible, we don't miss our mark. What you can also see on this image is that we're not just contouring out the target within the scar that we want to hit with the X-rays. We need to identify, contour out the organs at risk. And in this case, what's critical for us is the rest of the heart itself, but we've also got the esophagus nestled nearby there. And we've got just below the heart, below the diaphragm, the stomach. So these are highly radiosensitive structures, in fact. And I admit I was biting my nails. I still bite my nails when we bring these patients to our department. Number one, we usually always are striving to avoid the heart and minimize the dose. And in this case, we're our target is carrément in the heart. And then, of course, we're delivering high doses of radiation to targets that are kissing esophagus, kissing the stomach in this particular case. So that's the challenge. We want to give the dose to the scar, and more specifically the area within the scar that is the trigger point for the VT circuit. But we do need to minimize, we do need to respect the tolerance dose of the surrounding organs, so that we don't solve one problem just to create another, i.e. severe irritation of the mucous membrane of the esophagus or of the stomach, which if we don't respect could, in the worst case scenario, potentially lead to severe ulceration, ultimately a potential perforation, which has never happened so far. Next slide, please. Another view, and you can imagine all of us are sitting around the table, meaning to say the radiation oncologist, medical physics, but also our cardiology colleagues to manipulate and turn these contours in 3D, sort of playing with it virtually, if you will, to get a sense of whether or not we've got a sensible volume that corroborates well with the voltage mapping that we did previously. The perfusion scan, etc. In this case, we didn't, as you may remember at the beginning of the case presentation, creatinine is terrible, chronically elevated. So I would have loved to have done an infused CT scan, but not possible in this gentleman because of his chronic renal failure. Next slide, please. So once we've all voted on the final target volumes as shown there, then we need to begin the dose calculation process, and we give instructions. There are specific dose constraints, dose volume constraints that need to be applied to all of the organs at risk, as already described: esophagus, stomach, lungs, spinal cord, and it's an iterative process done with computer-based calculations. It's the only way to do such calculations. It's all automated, but we need to feed these instructions and the priorities to the treatment planning software system, which then runs the calculations and gives us the result. And ultimately, then we need to review the plan and sometimes make compromises, adjust our priorities, and see where we're happy, where we're not, and make some choices. Next slide, please. And this is our final slide with respect to the evaluation of the final plan. As I mentioned, biting my nails about actually hitting the heart deliberately. Reassured by my cardiology colleagues, however, that although you don't have a nice, neat tumor to target, bear in mind that what you're hitting within the heart is not viable cardiac tissue. We're really going after a scar. But nonetheless, there are substructures within the heart that are viable, that need to be respected as well. But the question is, and it's still a work in progress, what should be the dose volume constraints that we strive to respect for all these substructures in the heart? We don't have the answer. What I'm showing here in this table, in fact, are the average doses that were delivered to these structures by the WashU group in St. Louis. So here we are at McGill, giving it a go ourselves, and we were using their median doses to these structures as a guide to help us in our planning process, striving to at least respect, come as close as possible to respecting the median doses that were delivered to these structures. Hoping, of course, that based on the very positive experience at WashU, the very little toxicity reported, that by achieving the same sorts of medium dose, respecting these dose constraints on these structures, would give us very safe results for our patients as well. So there we go. I think that was my last slide.
Okay, so my turn. We're going to just talk a little bit about the physics here. So I'm not a doctor, I'm a medical physicist. My goal would be actually to show you how we deliver the dose to the patient, how we manage to create the treatment plan. So next slide, please. I'm going to go over a little bit of the things that Dr. Kopek already said, but like I said, we need to actually irradiate the heart with these X-rays. So we need to actually position the machine at different places around the heart and then shoot with the X-rays for a certain amount of time. At the MUHC, we have access to conventional linacs, like the one on the right from the Varian company, and also to the Cyberknife, which is a kind of a miniature linac mounted on a robotic arm that is able to move around the patient, but also in some non-coplanar situations. So we had access to these two machines. We can advance, please. And kind of for me as a medical physicist, the first kind of red alert was the fact that we never treat the heart in radiation oncology. We actually do everything we can not to treat it, even when we treat targets very close to it. So here I'm showing you an example from other patients in a lung treatment, lung tumor very close to the heart, and we managed to use our machines to treat with arcs that are not passing through the heart, and actually the dose to the heart in these patients are very low. We see 4 gray on the left side and about 1 gray on the right side, which is an example of a conventional radiation therapy for a breast patient, left-sided breast. Once again, we do everything possible not to actually irradiate the heart, so we have very little information on heart irradiation at all. Next slide, please. And as already showed by Dr. Kopek, actually the doses that we actually deliver in the heart are quite large. So in this case, we give about 11 gray, we can say, to about 20% of the heart in heart SBRT treatment. There's just no way around it with the technique and the technology available. The targets also are a little bit non-conventional, I would say. We're used to have kind of more spherical or kind of solid shaped targets, whereas this is basically a surface, a long, very long surface around the, even we can say it's sometimes a donut shape, depending on what views we're looking at, like Dr. Bernier said. So there's just no way around actually delivering a little bit of those to the heart. Next slide, please. So that was new, and we typically use constraints to actually guide our treatment planning. And because the heart is actually a very large volume, we tended just to avoid the heart, but now we cannot avoid the whole heart, but we can still try to avoid subregions in the heart. So we asked to create contours of substructures in the heart. And then with these substructure contours, we're actually able to show the doses received by these substructures. And maybe for now, we're not using that to modulate our planning, but we're actually using that to aggregate the data and then decide in the future whether we would like to maybe spare some substructures more than others. So next slide, please. So with that in mind, we had still the choice with whether we will use a conventional linac with arcs or the Cyberknife approach using the robotic arm. So we can advance slides, please. And for this patient, we tried doing kind of an attempt on the Cyberknife for a plan. We were able to have a nice plan, but there's two problems with this. It's on the Cyberknife, actually, the delivery would be very long, which would be more than 2 hours compared to about 20 minutes for a conventional linac. And the second problem was just the imaging on the Cyberknife is a little bit weaker in the sense that we would need to have markers implanted surgically close to the target that we want to treat in order to be sure that we're treating the right position. So next slide. For this reason, we decided to opt for the kind of easier treatment with the conventional linacs. And at that point, once the contours are created by the radiation oncology team, we actually start the treatment planning process. And Dr. Kopek already said that it's kind of an iterative process where we actually create many different treatment plans using the software. And I'm showing here a screenshot of this treatment planning software that we use, where there's many different plans that are shown to the doctors, sometimes not even shown because we exclude them before. And we compare all of these plans using different tools, both color wash, so just showing the dose on the patient, but also some constraint tools like the dose volume histogram. So we always try to respect the prescription and also the constraints on the normal tissue, and also make sure that the plan is actually deliverable. So next slide, please. And that's my last slide. I'm just going to show you two little movies. So, I mean, it's just on the left side, we see a movie where, if you can click on it, just basically how the treatment process works. So actually for the treatment day, the patient comes in, walks in the treatment room, lays down on the table by himself. The linac is going to rotate around the patient for about 20 minutes and irradiate from different positions. And every time the linac irradiates, now we can look at the right movie, we're going to see the opening of the linac. So this would be the opening of the linac. And at every different position, we have these multi-leaf collimators. So these are basically blocks of metal that are going inside of the beam in order to shape the beam to the target that we want to irradiate. However you look at it and however angle you choose, you're still going to irradiate parts of the heart and structures around it. So my goal, or our goal as a team, is to kind of minimize everything that is not target. Thank you. Oh, sorry, there was another slide. Actually, this is actually also a quite important one. The only thing that we didn't talk about is how do we actually make sure that we deliver the dose at the right spot? And this is done with imaging at time of the treatment. And so once the patient is lying on the table, we actually need to apply, to acquire KV radiographs. So we apply a pair of KV radiographs like you see on the top, basically only to kind of set up the patient using the bony anatomy correctly. But then also we have access to a CT during the treatment. So we call this a cone beam CT, a little bit of a worse quality CT than the diagnostic one, but good enough for us to actually visualize soft tissue inside of the patient in 3D. And we're able actually to position the patient where we need to, because we're not able to necessarily move the linac, we're moving the patient so that the patient is in the right spot to deliver the treatment correctly. Thank you.
Thank you, Piotr. I'm going to continue with the clinical trial that we've passed through REB recently. Next slide, please. So there are many questions. As you saw, especially the part that Ian presented, we don't know what is the optimal dose. Can we give one treatment or several treatments? What's the ultimate expected efficacy? Which are the patients that would benefit most from treatment? How can we minimize the volumes treated to minimize side effects, but still have a good effect? And biology is not understood. So we thought that the scar was important. Now we think that the effect might be due to something else. Next slide. So we decided to answer one of these questions, and we're opening a phase 2 dose de-escalation non-inferiority clinical trial at the MUHC. The question we're answering is about dose. We hypothesized that a single dose of 20 gray is non-inferior to the standard of 25 gray, and it's a single arm, open label, non-randomized, non-inferiority design. Comparator is historical controls. We plan on accruing 9 patients. Next, please. And who are we choosing? We're choosing adults who have recurrent episodes of monomorphic VT that have failed standard treatment with at least one antiarrhythmic drug, and who have a contraindication to electrophysiology studies. As long as we can, as long as we can, using non-invasive methods, be able to define the arrhythmic substrate. Next. So we would enroll and allocate to that single arm 20 gray SBRT with 4D CT simulation, and we would follow patients with EKGs, echoes, remote ICD monitoring, and in-person assessments. And the study would be analyzed at 6 and 12 months after the 9th patient is treated. Our next slide, our primary endpoints are, first of all, changes in arrhythmia burden measured by number of VT events and number of ICD events, comparing the 20 gray treatment with the historical 25 gray, and acute radiation toxicity in the first 90 days after treatment. Next slide. We also have secondary endpoints, which include late radiation toxicity, changes in the number and dosages of the antiarrhythmic drugs, patient-reported outcomes, and overall survival. Thank you. And next slide.
Yes, so it's already 12:49. I don't want to spend too much time. Next slide. The patient recovered well from the treatment and was essentially arrhythmia-free for 2 years until he developed recurrent VT down the road, which was later found to be a repeat VT study to be originating from a slightly adjacent but different area than the one that was originally treated, and perhaps in an area that was that evolved over time, or an area that was clinically relevant that was not. And there is a little bit of data on early success and sort of late recurrence. So it's just highlighting how challenging it is to define the right amount of scar that you're going to target that's clinically relevant without radiating too much. And there's sort of an upper volume that we try to not cross in terms of having treatment plans that are so broad that you're irradiating too much of the heart, over a concern that this might be associated with worse clinical outcome. So you have to sort of be relevant, very selective. It's still very much evolving and challenging to define that. Certain patients will have one VT from one discrete area, but many patients, and especially as they're further along the way clinically and with severe heart failure, will have several VT morphologies. And I think that was one of the, is there any, another slide? Yeah, so that was slightly sort of more basal inferior. The lateral wall was targeted, and this was more sort of inferior portion. Next slide. And yeah, patient did well subsequently on. Still not off antiarrhythmic at this stage, but off the mixility, sort of was tapering. Next. Yes, we'll leave a few minutes for questions.
Thank you so much, Martin and Tarek and everyone, for your wonderful presentation and your innovative work. The floor is open for questions if you want to just enter your questions in the chat. So I have a question for you. How applicable is it for people, like what percentage of people do you think could benefit from this?
I mean, it's gonna, at this point, I only see that as a very marginal sort of fourth line, fifth line type of tool for people that have failed standard therapies. I mean, this, you know, after what we just presented, we have to sort of remind ourselves that standard therapies do work, and we have increasing data to say that they work reasonably well. So ablation in particular, and so on. But there remains a subset of patients. And in our experience so far, so we've been doing this for a few years now, it's approximately 2 patients per year. We're a reasonably high volume center, and 2 patients per year that will end up qualifying and sort of being deemed eligible for this type of treatment. And that's, you know, since by now we've had a few referrals from other centers that know we have developed this program, and sort of nice expertise, as you can imagine from having heard everybody speak. Everybody's been very enthusiastic, and the program is took off, and we've had a few referrals from outside. And in spite of that, it still remains a very low recruitment with very small numbers. And I don't see that evolving or changing soon because of the particular toxicities and risks and uncertainties inherent to the treatment.
There's a question in the chat. How realistic, from Dr. Freeman, a radiation oncologist, how realistic is the clinical trial if only 2 patients are referred per year, knowing that we need 9 patients in our dose de-escalation trial? Joanne, would you want to answer that one?
Sure. We obviously did take into account our accrual rates, and so we sort of planned to not have more than 1 or 2 patients per year, with a very early interim analysis for safety, which is planned. We would hope to have more patients per year, but again, they're highly selected, and patients who really this treatment ends up being a last resort. So very difficult to accrue. I think your question is valid, but any center in that situation is in the same situation. One way to go around this obviously is to design a multi-center trial, and we are reaching out to our colleagues in other institutions in Montreal, Quebec, and Canada to be able to perhaps extend our population accrual to other institutions.
Fantastic. Can you give us an idea of the cost of this technology?
So go ahead, Martin. I'll give the radiation part after you.
Yeah, well, I mean, from the electrophysiology standpoint, we've had a range. Some of the first patient had an EP study, actually more than one. So there's cost inherent to catheters and so on, which is no different than what a patient would get if he was to go solely for an EP study. We have since done a few patients that had complete contraindications to EP studies and were completely non-invasive. So the treatment that included scans, PET CTs, CT scans, 4D CTs, like you saw, echoes, and so on. And this is what we used for the mapping part. And as far as the radiation oncology, Tarek will tell us that these are standard tools. But Tarek, if you want to say from your point of view.
Yeah, so radiation oncology is actually financed by the activity. So we do cost everything we do, and our financing depends on that. I don't have the exact numbers, but this is, although it is very technological, it still resembles some of the more advanced techniques we use to treat cancer. And we would expect it to cost approximately $2,000 for a treatment for a patient, all included from the departmental point of view.
Thank you so much. It's coming on the hour. I'd like to thank everyone for your presentation. Really outstanding work, really innovative. And I think it's a perfect type of treatment for an institution like MUHC. And I hope you do well with your clinical trial and get to randomize all the patients you want. I'd like to thank you all for sharing this with us. And I wish, thanks everyone for participating, and wish everyone a great afternoon. Thank you. Bye-bye.
Thanks.